Well, ladies and gentlemen, good morning or good afternoon or good evening, wherever you are. My name is Osama Tawfiq. I'm the current president of the Society of Egyptian Pathologists in North America, which we call it SEPNA or EASE, as well as a professor and chair of pathology at the St. Luke's Health System in Kansas City. For whoever doesn't know where Kansas City is, get the map of the United States and get smack in the middle, and it will be there where Kansas City is. Before the introduction of our distinguished speaker today, I would like to take a couple of minutes to talk about a wonderful video that was produced and given by His Excellency, Dr. Khalid Abdul Ghaffar, for his support of the society. And I would encourage you to visit that video. We have it on social media, on our Facebook page, on our Twitter account, and on our website. His leadership and encouragement has created tremendous publicity for the society. For that, we hope and wish that we are worthy of this support and trust. And while we're at it, also, Dr. Ahmed Al-Gohari, my dear friend and colleague, who's also the main person behind this collaborative effort, as he is a counselor for the Minister of Health. And this idea was his brainchild. He was very helpful and supportive for us to give us the opportunity to reach out with our colleagues in Egypt. So thank you again, Ahmed, and we appreciate and thank you very much. I have a few reminders before we start the lecture. Please mute your speakers and turn off your videos. Questions will be sent through the chat box, or if we have time, we can have an opportunity to talk. But depends on how much time we're left with. I remind you that these lectures, all of them are recorded and will be uploaded immediately on the Society's website and YouTube channels, as well as Twitter and other social media for your convenience and further reference. As always, we appreciate your feedback to improve our experience and your comments about your interest in certain topics that you would like us to cover in the future. Without further delay, it's my honor and pleasure to introduce Dr. John Diks. John is an assistant professor at the Marshall University with special expertise in cytopathology and surgical pathology. He graduated from Cairo University, where he also served as a junior faculty. He completed his residency in anatomic and clinical pathology at SUNY Downstate Health Science University. This was followed by a fellowship training at MD Anderson in surgical pathology and in cytopathology. Dr. Diks has many clinical interests, including fine needle aspiration, like what we is going to be talking about today, oncologic pathology and molecular pathology. As you will be seeing soon, he is deeply committed to medical education, mentoring both medical and pathology residents, and his current research focuses on the integration of artificial intelligence in pathology, a field he plans to explore further in upcoming publications. The title of his presentation is pancreatic EUS, fine needle aspiration, confronting diagnostic uncertainty. Dr. Diks, the floor is yours, and welcome aboard.
Okay. Thank you so much, Dr. Osama, for this wonderful introduction, and thank you for having me. It's an honor and pleasure and joy to see this society getting bigger and getting publicity. And thank you, Dr. Gori, for all your efforts to get us connected to our colleagues in Egypt. So, without further ado, pancreatic EUS-FNA is still a little dilemma, and every time still now I get an FNA from pancreas, it gives me shaking, and I believe everyone else is the same. We have small cells, a small specimen, and we need to give the patient a diagnosis that might get him his pancreas away, like Whipple surgery or something, and will affect his life. So we need to be so cautious about everything we say in the report or in the immediate assessment. Without further ado, these cases I encountered while I was doing my fellowship in MD Anderson. That's why you will see the logo of MD Anderson here. And also I am including the logos for SIBNA and the MOH, as it is a collaborative sponsorship. So the eye can't see what the mind doesn't know. Was said by Dr. Ali. He is a great cytopathologist in Johns Hopkins and a well-known one also. So if you don't have it in your mind, you will not think about it. So in the WHO, the reporting system of pancreatopapillary cytopathology, the latest version 2023, they are saying that you should have this algorithm for pancreatic neoplasm. You need to have this diagnostic algorithm. You can't do it only on cytomorphology anymore. You need a multimodal approach: clinical history, radiological imaging, cytomorphology, biochemical testing, immunohistochemistry, and molecular testing. This was said by Dr. Pittman, Marcia Pittman, one of the eminent cytopathologists in Harvard. So before we dig into this algorithm, which we will apply for all our cases today, we need to think about our methods of sampling. Why? Because of the contamination. Because when the needle goes through all of these layers, you will have a contaminant, and you need to differentiate between the contamination and the real pathology of the cystic lesion or the lesions that you are sampling. So the method of sampling, easy for the pancreas, it's EUS, endoscopic ultrasound guided FNA, or transabdominal ultrasound, or computed tomography, CT guided biopsy. Our focus today will be on the EUS-FNA, endoscopic ultrasound guidance. So this is a probe, this is the ultrasound probe, and this is your needle. And as you can see here, the ultrasound is contacting the stomach, and the needle is going through the stomach, then the pancreas, and then the lesion. If you are going from the duodenum, it will be the same. You are going through the duodenum, pancreas, and then the lesion. So all of these layers can have a contamination in your sample. So a little refreshment about the pancreas. In the pancreas, you will have acini, ductules, and duct. And between these acini, you will have your islets of Langerhans, which is basically endocrine cells. And these are different. So how to differentiate acini from the ductal cells? Because it will be there. So the acini basically have acinar, and the cytoplasm is a little dense because it's a little vacuolated. The acini is secreting something. So these cells having vacuoles of whatever they are secreting, and they are arranged in acinar shape. The ductal, on the other hand, is like a fence packet or honeycomb. And it's basal. If you see it in the fence packet, it's a basal nucleus, and it's apical, a little mucinous. So what about the contaminant? How we differentiate? If you have it from a CT scan, a CT biopsy, you can have some mesothelial cell. So the mesothelial cell, how to differentiate that from the honeycomb? You have two things in your mind. First of all, there is an intracellular windows, which makes by the villi of the mesothelial cells, and we can call it like a skirt. You will have on the periphery of each cell something lighter than the cytoplasm itself, and you can go between the cells and see this whitish between the cells. Hepatocyte, if you are going by ultrasound and getting into the liver by mistake, you will have some hepatocyte. You will have some prominent nuclei, sometimes lipofuscin pigment, which is like granular golden pigment. Also, if you are going from the duodenum, you will find a lot of like honeycomb which is have surfaced by some columnar cells intermixed with a lot of goblet cells. So, which is a very, very delicate when you are trying to see if this is IPMN or not. Intraductal papillary mucinous neoplasm, because it has also goblet cells. So how we can differentiate between these both, we will see later. So the gastric mucosa also, this should haven't a lot of goblet cell. You might have goblet cell, but a lot. And it will be also mixed with extracellular mucin, which is a little pitfall for calling anything mucinous neoplasm. So the WHO have a reporting system for pancreatobiliary cytopathology. This is like a 7 category. The first one is insufficient, benign, atypical, pancreatic neoplasm with a low-grade suspicion, or pancreatic neoplasm with high-grade dysplasia, suspicious for malignancy or positive for malignancy. And they have the risk of malignancy with each category and what to do if we get it into one of them. So without further ado, I shared with them earlier the cases, the histories, and the whole slide image. So if anyone want to interact with me, this will be great. If not, that's fine. So the case one, it's a female. It's a 29 years old. She had a history of well-differentiated neuroendocrine tumor, carcinoid tumor, in the lung, found incidentally on the image because of car accident. So she has a car accident. She found this on the imaging. They got a biopsy. It is a carcinoid, and they take it out. And after a little bit, she came back for a surveillance, and she found a pancreatic tail mass, 1.2 by 1.9 centimeter. So this is a carcinoid tumor. This is a CT scan, and you can see this is a big one. And this is a like excisional biopsy. And you can see this is a clearly carcinoid tumor. So the EUS finding, as you can see here, there is a hypoechoic, but it's well defined, 1.9 by 1.2. And here in the other image, you can easily find the needle going through this solid mass, okay? And this was in the tail. So the smear here on the intermediate power, you can see like groups of cells, and these groups of cells is connected somehow by something. And when you go higher power, these cells have something like tubes. Do you see this tube? Can you track it? So you can say it if I'm going higher power, but it's better to appreciate it in the intermediate power. This tube is not the only one. There is many of them. So we call this transgressing vessels. So these are vessels are going from one area to other. And it has some cells around it. These cells, this is a diff quick. So we are just saying the cytoplasm and maybe a little of nuclear characteristic, but not much. So to better find a way, you need to see the sparse cells. These, you can't appreciate what are these cells in the clusters. You need to see the individual cells. So these cells looks like here, you have a trilobed cells. This is a neutrophil. And here, maybe they have like a coarse granulation. Maybe this is an eosinophils. It's not bilobed, but it's a coarse red granules. And you have a lot of small cells that doesn't have much cytoplasm, which I think it's a lymphocytes. So this is like a mixed population of different cells. Going to the PAB, And let's see some nuclear details. And first, let's see, is there a transgressing vessels? Yes. There is a lot of these vessels. See? It's like a star here, if you can see it well. And the delicate cytoplasm of the lymphocytes makes this smear with a smearing effect, can give you this artifact. But still, the cells have small cytoplasm around them, which proves this is most probably lymphocyte. And we have some neutrophils, as we saw, and some eosinophils. So this is a good pictures, better pictures, I believe. See here, this is a mixed population. Still the same. And this is the transgressing vessels from the PAP. So Mayo Clinic has a chromogranin A serum marker. This is for surveillance of patient of known or treated carcinoid tumor. So they see how activity, what is the activity for these tumors. So here it was high, it was 289. So at this point, what is your differential diagnosis? Are we talking about something benign? Are we talking about something malignant? So in your background, in your head, you need to have all of this list of differential diagnosis. But the most important one is splenosis or accessory spleen. This is sometimes doesn't go into your mind. So could be a pancreatic neuroendocrine by radiology. This could be solid papillary because of the transgressing vessels. Could be a chronic pancreatitis, but chronic pancreatitis doesn't have all of this mixed population. They might be going through a lymph node, very pancreatic lymph node. Might be a papilloma, lymphoma. Might be extramedullary hematopoiesis. Might be anything. So let me show you the cell block. So we have a cell block from here. And as you can see, this is the same mixed population of lymphocytic cells and inflammatory cells. And there is something grabbing around them here. It's like small endothelial cells. We did CD31 to prove these endothelial cells and CD8. CD8 is a little specific for some entity. And as you can see, CD8 is not only for the T cells, but it's staining the endothelial cells around these sinusoids. We did CD3 and CD20 to prove this is a mixed population of lymphocyte. And the final diagnosis is a benign spleniole. So this patient has a spleen in her pancreas, an accessory spleen in her pancreas. So this is a congenital anomaly. It happens like 10 to 15%. It happens at the splenic highland pancreatic tail, most common. And radiologically can mimic anything like pancreatoneuroendocrine or solid pseudopapillary, or even pancreatic adenocarcinoma if it's like a splenosis. Sometimes when the spleen is ruptured or have any hit, some of the cells go through all the peritoneum and create something called splenosis. So cytological feature, well-defined border on the radiology, solid, and it's a small, or mostly small, and it's hypervascular. On the cytological feature, or the cytological in the smear, you need to see polymorphous population of hematopoietic cells, a small transgressing vessel or transversing vessel, and you can prove it with the CD8 staining the endothelial cells of splenic sinuses. This is very specific since systemic endothelial cells doesn't stain for CD8. Chronic pancreatitis is a grungy material. You need to have a grungy material in the background, which we didn't see in this one. You need to see some fibrotic stroma, and you need to see some epithelial cytological atipia. We didn't see any epithelial component in our slide, so we can't call it pancreatitis, or at least going. And for the atipia here, I am talking about a little nucleolus in each of them, not like a big thing. They still have a honeycomb appearance. They still have respecting each other. They are not going overlapping or polymorphism. Case 2, female, 66 years old. She has a peripancreatic mass, 1.8. by 1.3, and she status post Whipple resection due to pancreatic adenocarcinoma. So here we have a history of pancreatic adenocarcinoma. And on the surveillance, they found like a little thing coming in the bed of the pancreas before its neck. So a Whipple resection doesn't take all the pancreas, it just takes the head and the duodenum. So you still have the tail, and in the middle or the neck region in the bed, they found this mass 1.4 by 1.3. And they did beta scan, as you can see. So the beta scan here is a little vivid. It's not like much vividity. It's like 6.5, but it still makes them suspicious. And they found another focus medial to it on the left side here. It's 4.2. And you can understand this is a hilum of the kidneys, so doesn't count as vivid, as bit avid. So this is the EUS finding. You can see it's not regular like the first one. It's a little irregular. It's mostly solid. And here you can see the needle going through the solid part. So here we have this is smear. This is a diff quick. And we have these cluster of cells. And once you go to the individual cells, you will find that a lot of vacuolation. This is like some polymorphism in the nucleus, but there is a big cytoplasm, and this cytoplasm is filled with vacuoles. Here also, filled with vacuoles. So this is you need to put in your mind. On the Pap smear, you can go back again here. So these are cluster of cells going together, and they have a very well-defined cytoplasm. And if you can go here in the clusters, you can find like some granularity. It's not the best image, that's why I'm having some image for each cases, but I'm trying to give you the best shots here. So here, this is the diff quick. You can see the vacuolation, and there is some like nuclear polymorphism, anisonucleosis, I'm sorry. And here, this is the best of the BABs. So you can here see this is like vague acini or like vague clusters, and there is some lipofuscin pigments here, like golden pigments, and it's very granular. So the labs, the CA19-9, the tumor markers are high. CEA is high. And the differential diagnosis, you are now having the smears, and you need to give a diagnosis for your clinician. Is it a clear cell carcinoma, renal cell carcinoma? This is like very vacuolated cells and very clear cells. Is it clear cell renal cell carcinoma? Is this a recurrence of pancreatic ductal adenocarcinoma? And what you need to put in mind in this case could be this adrenal rest or adrenal gland. This could be adrenal cortical carcinoma also, or acinar cell carcinoma, which is having the granularity but doesn't have the typical atibia for acinar cell carcinoma. Could be solid pseudobabylonium, very less likely. We didn't saw all of other feature of that. Benign splenially, I didn't see any transgressing vessels in this smear. So this is the cell block, and we did a Milan A here, and it was positive. Milan A is one of the markers to tell this is adrenal gland tissue. And the left-sided SUV was actually adrenal gland adenoma, adrenocortical adenoma. So the most common metastasis to the pancreas is the CCRCC. I have a case here in Marshall, and our cytotext called it benign because they saw some gland cells, and these cells are like having clear cytoplasm. And once we did BAX8 on this, we found out it's a clear cell renal cell carcinoma. The patient has a renal cell carcinoma mass and was biopsied, and it was a metastasis. So They did like 1.107 cases in MD Anderson, and they found like 50 of them, or 48 to be exact, is a metastasis from CCRCC. So this is something you need to put in your mind. Adrenal rest, adrenal tissue heterotopia can be anywhere, and it can like implant itself anywhere. So this is large polygonal cells, and the cytoplasm is big. The NC ratio is small, and you can find some atypia because of the activity of these cells. The positive marker is SF1, Milan A, and Inhibin A, and it should be negative, basically negative for BAX8. Case 3. So we have a female, 48 years, pancreatic head cyst with solid component. So we have a cystic and solid component here. And she has a history of invasive mammary carcinoma. We didn't have a full history of if it's ductal versus lobular carcinoma, but we have a history of invasive mammary carcinoma. And now on the surveillance, we found the cystic solid mass. So a lesion is noted within the pancreatic head. As you can see, this is a CT scan, and this is a pancreatic head. It's like 1.7 by 1.7. And the EUS show this, there is a solid component and there is a cystic component. This is a cystic component and this is a solid component. On the smears, it looks cellular for me. And if you can go higher power, it's a little, some of them are like a little discohesive and some of them are arranged around vessels like this. This is like a great picture for this entity. So you can see this vessel going through, and the cells are arranged around this like a corn stalk or something. It's very beautiful. And these cells, if you can go here, some of them are like a little vacuolated, some of them like this one with eccentric nuclei, and plasmacytoid. You can think about neuroendocrine in this. See? This is vacuolated, and this is, I have like eccentric nucleus. It might be a neuroendocrine, might be. So the BAB, let's go to the PAP and see. Do we have the same like vessels and the cells arranged around it? I believe so. So this is one of them. It's not very focused here. Maybe this one. You can have like vaguely see some vascular cores and the arrangement. Here. See this? So also there is a very good morphology that you can see here in the individual cells. See, the cells have eccentric nuclei and the tail of cytoplasm. See? See this tail of cytoplasm here? See? So this is called circariform cells. This is a little unique for this entity also. So this is what I showed earlier on the DiffQuick, but a better image for it. And you can see this magenta or metachromatic hyaline myxoid stroma between the vascular core and the cells. It's amazing. I like this image. And here it's in the BAB smear. See, this is a fibrovascular core here, and this is like the cells around them. So the CA19-9 tumor marker was low, and your differential diagnosis here should include solid pseudopapillary neoplasm or pancreatic neuroendocrine. You can include acinar and you can entertain benign splenic. IHC on the cell block shows SOX11, which we will talk about, which is nuclear marker, beta-catenin, and if you can look closely, this is not only cytoplasmic or membranous, also nuclear, which is a huge difference. Nuclear beta-catenin is a big clue for you for this entity. Synapto and chromogranin was totally negative, and synapto is a little sensitive but not specific, so they can pick it up. So even if you have some positivity for synapto, you shouldn't be calling this neuroendocrine. So this is solid pseudopapillary neoplasm in the patient which have history of invasive breast carcinoma. And this is the resection. As you can see, the same, the histology is the same like the cytomorphology that we saw. So case number 4, which is closely related to case number 3, I will discuss them together and then we will include the differentials. This is a male and 43 years old with a nodule and has a cystic component in the uncinate process of the pancreatic head. So this is also cystic and solid, but it has a cystic component. As you can see, this is like some cysts inside the uncinate process. And this is a solid component. Here is a hypoechoic nodule in the uncinate process. And you need to make sure that your needle or the gastroenterologist needle coming through the solid part. Because if you didn't have it in the solid part, you will be examining the cystic part. And this is a little different. So on this one, we have a little less cellular, but the disc cohesiveness here is more. There is some plasmacytoid. The nuclear is eccentric, and the cytoplasm is big, as you can see here. So this is a little plasmacytoid. And it's disc cohesive. They are not going around clusters. I don't see any transgressing vessels. I don't see any fibrovascular cores. I don't see any like any of these other things. The background is a little clean, and here you can see more. See? So the nucleus is eccentric and it's having this huge cytoplasm. On the pap smear, we can see the same findings. So this is not the tumor. This is a distractor. This is a honeycomb appearance. This should be either pancreas or a stomach, like a bowel. So you don't want to look at these. You want to look at the individual cells here. Yes. These individual cells that you are looking for. See? Where else? See, this is your neoplasm, not the other way around. So keep away from your distractor and your smear. So this is a diff quick image, as we said. And look here, there is some, this is the pap smear. This is I was looking at in the pap smear. So there is some vague, I didn't see a tube going here, but there is some vague fibrovascular core here that we need to put in mind. So serum tumor markers, chromogranin, Mayo Clinic invented a serum marker for patient who has a carcinoid tumor anywhere, was low, 57. And the pancreatic polypeptide plasma, this is another one Mayo Clinic invented. This is for pancreatic endocrine tumor. This is highly specific for it. It was like 564. So your differential diagnosis here should include solid pseudopapillary. We have some vague fibrovascular core. You should entertain pancreatic neuroendocrine. You should entertain benign splenomegaly, and which less rare acinar or plasma cell neoplasm. Here, when we did chromogranin is positive, diffusely positive for synapto, beta-catenin, as you can see here, it's cytoplasmic, it's not nuclear. And the Ki67 here is very low. So it was signed out as neuroendocrine tumor, well differentiated. So solid pseudopapillary, which is related morphologically with the neuroendocrine, it's mainly in a female. You will always find this in a female, between 20 and 30. Our case was 48, so it's a little away from the range. But the tumor layers should be arranged around capillaries, like this one here. And you have this pericapillary metachromatic myxoid or hyaline stroma that I showed you. I will show it to you here. See? This is the metachromatic hyaline stroma that we saw. And the circariform morphology is very unique for it. You can see it here. Very unique for solid pseudo-papillary. The solid pseudo-papillary has a CTNNP1 mutation, which makes the beta-catenin is the perfect marker for it. So it's beta-catenin nuclear marker should be positive for nucleus, and even if it's cytoplasm, it's good, but it's nuclear marker for solid pseudo-papillary. CD99, and SUX11. SUX11 is a marker evolved by MD Anderson, and I will talk with it later. It should be for mantle cell lymphoma, basically, but it happens to have some sensitivity and specificity for solid pseudo-papillary in differentiating between it and neuroendocrine. CD56 is positive in solid pseudo-papillary, so and it's a neuroendocrine marker, so don't lean on that. Also, it can be focal or weak for synapto and pancreatin. So your morphology and your beta-catenin nuclear and SUX11, if you have it, are your clues. So SUX11 is a member of SUX-C group, transcriptor factors. It's located in chromosome number 2. It should be a marker for cell lymphoma, but have a sensitivity of 92 to 100% sensitivity for solid. So they did a paper on MD Anderson for SOX11, differentiating neuroendocrine from solid pseudo-papillary. So if you have a focal or diffuse nuclear staining for SOX11, it is a solid pseudo-papillary. It's totally negative, it's neuroendocrine or support neuroendocrine. So neuroendocrine, male and female, it's happening in both. And we have, in our cases, this was a male. Any age, but mainly from 40 to 50. It happens in pancreatic tail, more in the head. We have it in the head. It's round, it's well circumscribed, and the population is polygonal as any endocrine cells. So it's a cellular aspirate. It's loosely cohesive. Some of them cohesive, some of them discohesive. And you can see some rosette formation or pseudo rosettes. For IHC, here this is the beta-catenin. See, this is cytoplasmic, membranous, but it's not nuclear. So beta-catenin, negative nuclear, positive cytoplasmic. Synaptoendochromo and all of neuroendocrine marker will be positive. Acinar cell carcinoma is a little tricky because it looks like acini. So you will find like a little bigger with prominent nucleoli and granular cytoplasm. But if you didn't put it in your mind in background, you can miss it. So for the IHC, you will have to have chromogranin and trypsin and chymotrypsin with a sensitivity more than 95%. So to base out or to have you a little free time, falafel come as a pharaonic dish. So this is coming from Rechmi Ra tomb paintings. So they found out that our ancestors have this fava beans bags to be given to Ra as sacrifices. And they started by, they have this fava beans, red seeds or red beans, and they put it in a hound to separate the shell from the bean itself. And then they swift it till become a little smashed and take out the shell from the bean. And they add some water and they have like funnels to make it like a cake, oval or rounded. And they put it on the, as you can see here, on the oil. And here also another painting. It's the same like we are doing it right now. And then they give it as a breakfast for Amun. So this is a very interesting, I didn't know this before, but falafel is a pharaonic dish. Okay, so case number 5. Female, are you with me? You still with me? Okay. So case number 5, it's a female, 73 years old, pancreatic tail lesion, 2 centimeters. There is a history of invasive ductal carcinoma of the breast. So this is a tail lesion in the pancreas, and there is a history of invasive ductal carcinoma. As you can see here, this is anechoic, not hypoechoic. It's anechoic, which means it's like the same like the other tissue around it. Pancreatic tail, it's a unilocular cyst. It's not multilocular cyst. And as you can see, when the needle is inside it and they aspirate it, it's collapsed completely at the end. There is no mural mass. There is no solid mass. So this is only unilocular cyst. When you go here in the diff quick, you will find on the individual cells, you will find what? Oh, we have these cells with a lot of a lot of what? I'm stuck. Okay, so we have these trilobe cells, which is neutrophils, and these cells, which is looks like histiocyte with a lot of vacuolated cytoplasm. So as much as you can see, all of these cells are neutrophils and macrophages, neutrophils and macrophages. If you go to the Pap smear, you will have the same. All of them trilobe neutrophils surrounded by macrophages. In the cell block, it's the same findings. So on the lab, pancreatic cyst fluid can be having analysis. We found amylase in pancreatic cyst very, very high, and CEA is very high also. Serum tumor markers is very high also, but this is a serum. So what is your differential diagnosis? Your differential diagnosis needs to have to see, is this acute pancreatitis or complication like pancreatic pseudocyst, lymphoepithelial cells, chronic pancreatitis, serous cyst neoplasm, is it an IPMN, is it mucinous cell neoplasm, is it maybe extramedullary hematopoiesis? Any of these things can be a differential diagnosis for what we have here. But we don't have any epithelial cells, and we have abundant of neutrophil and macrophages. If in appropriate clinical context, this should be a pseudocyst. Pseudocyst is the most common cystic lesion of the pancreas. It's happened because of the trauma. It happens because of the surgery. It's a unilocular, non-septated. It happens as a continuation of pancreatitis. It's almost always unilocular, not septated. It has a thick to thin wall, and there is no mural nodule. The histology shouldn't have any epithelial cell lining and histiocyte with inflammatory cells. The pancreatic pseudocyst should have some grungy background. We didn't have this. This was very clean in our smears. So there should be some cyst debris, blood, proteinaceous material, plus CA should be low, which we have it in our biochemistry a little high. Amylase usually should be very high, more than 1,000. We have 12,000, and the amylase here is like the cystic fluid analysis, like pancreatic cyst analysis. And there is no KRAS or GNAS mutations detected. Should be. Serous cyst adenoma is very unique. It has a radiological sign of like what it's called central scar and calcification 30 to 40%. It's multiloculated or multilobulated, and then these thin septa, it happens to be very weak. So when it have a lot of serous fluid inside, it break down and it invite macrophages to come. So you will have some epithelial cuboidal cells and macrophages or hemosiderin-laden macrophages. Most probably happens in a female, in an old age female. The cuboidal epithelium is glycogen rich, so you will have it as a clear cell in the histology. So cytological feature, you will have some cells, epithelial cells, and macrophage or hemosiderin-laden macrophages. CEA is low, amylase is low, no KRAS or GNAS mutation, and it can happen to have VHL mutation. So intraductal papillary mucinous neoplasm, you need to have an evidence of dilated main pancreatic duct, and it's communicating with the duct. So it's more than 5 millimeter. It's communicating with the duct. The branches or the main duct needs to be communicating with this radiologically before you call it. If you've only found a mucin, you can say this is suspicious for mucinous neoplasm. Uh, Third was multiple cyst. It has gastric type lining. It is mostly low grade. You can call it pan low for the sake of reporting, and you should have some papillae. So this is an example of IPMN with low grade.
بعتتهولي أماني والله ربنا يكرمها.
So here you can see some clusters, and these clusters is respecting each other. They honeycomb, they are not drunken appearance, they are not overlapping, there is no mitosis, there is no polymorphism, and it's a little high NC ratio. So this is qualified for low-grade dysplasia. And this is mucicarmin. You can use it on the cell block to prove there is intracellular mucin. IPMN with high-grade dysplasia, you need to see some action, some overlapping, some drunken honeycomb, but not yet 4-1 as pancreatic ductal carcinoma. You have here a large cells in comparison to others, and you have overlapping with the other cells, but you don't see any mitosis and you don't see any necrosis or like a very, very big cells and hyperchromatic cells. So you can avoid calling this pancreatic ductal adenocarcinoma. You can call it BAN-high as IPMN with high-grade dysplasia. So mucinous cystic neoplasm, should be a low-grade dysplasia or a low-grade neoplasm. Female to male ratio is 20-1. I can assure you, this one mostly never happen in a male. If you find this in a male, go check the charts. Is it a female or not? Because mucinous cystic neoplasm should have some ovarian stroma, and this is most happenly is in a female. Prognosis is completely excellent once it's accessed, it's taken out. This doesn't communicate with the pancreatic ductal system, which this is the information that you need to take from radiology. It is communicating or non-communicating with the ductal system. So biochemical and molecular tests, there is developed by many people. One of them is Dr. Marcy Pittman in Harvard and some group in Pittsburgh and UPMC. And they did like a molecular analysis to see if any mutation in B53, SMAD4 or B16, also KRAS and GNAS and VHL. So serous cystadenoma have a VHL, and GNAS is a little, and GNAS and KRAS basically is for IPMN, and KRAS, solely KRAS, is more with MCM. So you can find KRAS in mucinous cystic neoplasm. Pancreatic pseudocyst or pancreatic cyst should have a amylase high, CA low, and the others is variable for each. But serous cystadenoma should have everything low. So a group in University of Pittsburgh have this crazy idea to have DNA extraction from the cystic fluid of any cystic lesion in the pancreas and go hunting for mutations, KRAS, P53, B16, VHL, and other mutation. So they found out that if you have a KRAS mutation and more than 2 loci of allelic imbalance, loss of heterozygosity, you are dealing with a malignancy. This is very high predictive of malignancy. So this research resulted in initiating commercialized testing developed by this group called Pathfinder or Red Path integrated pathology. And they announced it that now it's available for anyone since 2022. UPMC with Pittsburgh have this next generation sequencing for cystic lesion or cystic fluid from cystic lesion of the pancreas. Case number 6, I hope I am on the time. Female, 60 years old, has a pancreatic mass 5/2 by endoscope. But when we see it on the on the CT scan, it is a huge lesion. It's like 7/6. The endoscope couldn't see all of it, so it gives it whatever he can see, which was like 5 centimeters from here to here. And you can see the needle going through all the lesion. So if you go through this, you will have this cluster of really having high NC ratio, hyperchromasia, and some of them even have multinucleation. The cytoplasm here is a little low, maybe have some vacuolation, but the more you go, the more you are scared. This is a little polymorphic, not little, this is diffusely polymorphic, very high NC ratio, and it has a hyperchromasia. Look here. It's really big. Compare it with the RBCs around it. You will find this. This can fit like how many? Like 5 RBCs in one nucleus. Here, can more than 5. The same findings in the BAPs. You can see it here. See? Here you can more appreciate the nuclear features. This have like nucleoli, a big nucleoli in each of them. So these clusters have, it's actually a cluster. You don't have a lot of discohesive cells. So they are clustering together, which a soft sign that you are dealing with epithelioid malignancy. So here, this is from the DiffQuick. Here, this is 100x oil immersion pictures. You can see this is a multinucleated giant cell. See, this is a neutrophil. You can compare this to that. This is a tremendous, this is huge. All your serum tumor markers are high. So your differential diagnosis here, this is a poorly differentiated epithelioid neoplasm. Maybe it's a poorly differentiated carcinoma. Maybe it's a metastatic poorly differentiated carcinoma from somewhere else. Maybe this is even something called pancreatic undifferentiated carcinoma. It's anaplastic carcinoma. It's the same like the anaplastic carcinoma you found in the thyroid. You can have a sarcomatoid type in this and rhabdoid type in this. This might be a carcinosarcoma. An entity that you need to put in your mind, something called pancreatic undifferentiated carcinoma with osteoclast-like giant cells. Why, we will know later. Giant cell tumor, which is like very low in your differentials. So the final diagnosis here, as a cytopathologist, called it poorly differentiated carcinoma. So pancreatic ductal adenocarcinoma have many criteria and features on the cytology. One of them should have like 4:1 anisosnucleosis. You need to have drunken comb, you need to have mitosis, nuclear atypia, and necrosis to call it. So with osteoclast, the osteoclast giant cell itself is not neoplastic. And why it is important, if you find this and it doesn't have a regular pancreatic ductal adenocarcinoma, this is a little more good prognosis for the patient. Last case, I think we don't have much time for the last case. Do you want me to continue, Dr. Osama, the last case, or open for questions?
I think let's stop here and have people have opportunity for questions. Great overview. The floor is open. Please unmute yourself if you want to ask questions. I see somebody is saying, please continue. Everybody wants to continue.
You want me to continue?
Yes, please continue.
Okay.
Okay.
Okay. So this is the case number 7. It's a male. It's 76 years old. It has a pancreatic head mass, 4.8 by 4.8, and this patient has a history of prostatic adenocarcinoma, Gleason score 9, and multiple lytic osseous lesion. When he presented for his surveillance, it has multiple lytic osseous lesion and there is a pancreatic head mass. So they basically think this is a metastasis from his prostatic adenocarcinoma. Clinically, I mean. So on the CT scan, you see this is a huge thing in the pancreas, 4.7, 5.2. Here you have this irregular hypoechoic. It starts from here to here, and you have the needle going in this solid mass. So on the smear, it is very cellular, but when you go on the high power, you can see these cells are mostly individual, disorganized, discohesive, and they are having this plasmacytoid, the eccentric. And if you can go through this, do you see the difference here? There is a perinuclear halo, and there is an outer layer of more darker. See here, this one here? Perinuclear halo and darker image on the outside. Let's see this. Okay, so this is an eccentric plasmacytoid, perinuclear halo, and darker outside, and this is discohesive. I don't see any transgressing vessels. I don't see any grungy background. I just see sheets of individual cells. Okay, so on the Pap smear, you will find the same, but with better nuclear details. See here? So it's the same, high NC ratio, and this is having prominent nucleoli and eccentric nucleus and some perinuclear halos. This is a better image from both. So differential diagnosis here, you need to put in mind with a Gleason score 9 and lytic lesion, you need to put in your mind, this could be a prostatic carcinoma. The other ones that you need to see or entertain, could this be a plasma cell neoplasm? Could be this a neuroendocrine? Could be this just a chronic pancreatitis? Is it primary lymphoma of the pancreas? There is something called primary lymphoma of the pancreas. So serum tumor markers all low or in the range. And we decided to give this to flow once we have it as immediate. On the flow, you will have this population, CD38, CD138, CD19 and CD38. And this is like CD138 positive. And this is CD19 and CD81. So it was a CD38, sorry, CD38, CD138. So it was a CD138, CD38, and it was lambda restricted. I don't have the flow for lambda, but this is our cell block, and this is the IHC. NKX 3.1 specific for prostatic is negative. Pancytokeratin is negative, but keep in mind, plasma cell neoplasm can have a Golgi or perinuclear positivity, diffuse positivity, apparent positivity for pancytokeratin, A1, AS3. So even if this positive, you need to look on CD38 and CD138 and your lambda kappa. So this was signed out as plasma cell neoplasm. Multiple myeloma involving the pancreas is a little uncommon. It's represent like 5%. It's very, very, very rare that you have a patient with prostatic carcinoma, Gleason score 9, with lytic lesion that is multiple myeloma involving the pancreas. This patient is like unfortunate patient, but it's very, very rare. Upper respiratory tract is the most common site for involving pancreatic involvement itself is very rare. There is something called the pancreatic plasmacytoma, which you need to put in your mind, because this can have a good response to radiation. So if this patient have only this pancreatic lesion and doesn't have this osseous lesion, this might be called a plasmacytoma, and it will be going through radiation, no surgery needed. So primary pancreatic lymphoma is a very literally rare lymphoma, but it happens, and it's extranodal malignant lymphoma, and it counts like 0.5 of all pancreatic masses. And this is all.
Wonderful, wonderful lecture and a tremendous overview of a very hot topic that we cytopathologists struggle with all the time. Thank you so much, John.
You are welcome, Dr. Osama. It is my pleasure to be here. I really having much joy joining the SIPNA and involving with it.
I have everybody saying thank you very much. Interesting cases. Thank you a lot. Very informative. Continue, please. And there is one question about what is grouchy background?
Grouchy background, it's like that's what you see in the inflammatory process as a chronic pancreatitis. I will show the slide here. So see, this is a grouchy background. So this is a debris, basically. You can't find any cells, but there is a debris everywhere. And you have like this scavengers or like macrophages coming to collect these things. So we call this grungy background, like a dirty debris background.
There is one buddy who's already recruiting you for another lecture, John. So I assure you, Dr. Maha, he will be giving another lecture. Actually, he signed up for a different topic, and then he decided that pancreatic EUS-FNA is probably going to be much more
Interesting.
informative.
Yes.
And I see why. But he signed up for one. Don't you worry. Well, I don't see. I have a question regarding rows during EUS-FNA. Okay, we can judge if the specimen adequate for diagnosis, but can we judge upon its adequacy for further molecular studies? That's a good question.
So the question is,
Like
regarding
they can
rows-
decide, rows can decide on specimen adequacy,
okay.
and they decide on whether it is adequate for molecular testing.
Yes, so in MD Anderson, the work is going like this. The gastroenterologist in the OR give you an immediate smears. Just you will have only DIF-Quick and BAB smears, and you need to decide this is a carcinoma or not. And if you can't decide on the smears, he will give you more smears. You don't have a cell block. You need to give him a diagnosis immediately. So it's mostly cytomorphology assessment. So the more you have, the more you can tell if the cell block will be going to be good for molecular testing or not. So on the rows, most of the hospitals here in US doesn't do it like MD Anderson do it. So it's basically the procedure done, and they just say, yes, it's adequate, and that's it. And MD Anderson, if we didn't have enough for molecular testing, we send the gastroenterologist again to the OR room to give us more. So this is the golden standard, I think. If you don't have enough for molecular, you need to give him or to tell him, go again, give me more. Because it will not cost you anything if the patient is in the OR room and you can get you more. But if the patient left the OR room and you don't have what you need for molecular, it will be like another round for the patient. and another round for the clinician.
I personally have a question and
Yes.
more of an information. We work very heavily with the pancreatic EOS in my institution.
Mhm.
And about 3-4 years ago, they switched the type of the biopsy
Mhm.
Specimen. Instead of getting us smears, they are now getting us nice
Right.
cores, which
Shark.
made my wife 100 times better and
Yes.
helps us for cell block, for whatever. And really is, they are microbiopsies, but they are outstanding. So we did a study where we compared our batting average of diagnosing lesions before they switch with the biopsy type. Can you comment on that?
Yeah, I will show you. So here, so they replace this needle with something called shark bite needle. And the shark bite needle can you give you a smaller course. It's not like a big course, but a smaller course that you can relate on. So the problem with these cores is one that I saw. It's beautiful. You can easily, if it's malignant, you can easily call it malignant and you can slide your case. But these cores sometimes miss the necrosis that you need to have. I saw a couple of cases called malignant because of chronic pancreatitis. So it was like fibrotic. It was squeezed, entrapping some atypical cells inside the fibrous tissue, and it was called as pancreatic carcinoma. And when the patient got the Whipple, we submitted the whole pancreas. It is negative. So the only pitfall for these scores that I saw is sometimes if it's chronic pancreatitis for a long period of time and you have entrapped SNI or entrapped glands in the fibrous tissue, you might call it suspicious or malignant. So these scores are really beautiful in solid lesion. In cystic lesion or cystic and solid lesion, you need the smears. You can't depend on the cores because they don't have sync to core. You understand my point here, Dr. Osama?
Okay. Usually, how many passes your GI people do?
So at Marshall, we have like 1 or 2 passes. At MD Anderson, we can get up to 5 passes, 7 passes, because we need to give a diagnosis at once. They need to give a diagnosis at once. So it's according to where you are practicing.
Very good. Well, I see no more questions. Thank you all. And I look forward to seeing you in our upcoming lecture, inshallah.
Thank you. Thank you, guys. Thank you for having me, Dr. Osama.